With that, I'll start off with presenting the first topic on the future of healthcare, fighting the opioid epidemic with alternative therapies. My name is Dr. Dasa. I'm the Vice Chairman of Orthopedic Surgery at LSU. I'm also the Director of Research for our department as well here at LSU in New Orleans. You can see my disclosures here. Today, we're going to look at the morbidity, mortality, magnitude, and scope of the opioid epidemic. We're going to look at some new technologies and innovations that are coming onto the scene. And then we're going to look at the costs of opioids and how they impact knee arthritis specifically. So in 2010, 20% of the patients in the United States were prescribed an opioid for non-cancer pain in the ambulatory care setting. 10 million Americans reported having misused opioid prescriptions in 2018. You can see the significant number of deaths in 2017. We all know that excessive prescribing has been an issue. I'm just as guilty of it as probably most physicians that are out there. Orthopedic surgeons represent the third highest prescribing specialty. And we disproportionately account for a significant number of opioid prescriptions. And recently, the AAOS came out with their guidelines showing or telling us that opioid use for knee OA should not be done. And so if a typical or common tool, which many of us have used to help manage our patients' knee pain, is now deemed inappropriate and that the risks outweigh the benefits, what do we do? What innovations, what technologies, what other options do we have that we can use? We know opiates can cause dependence and addiction, but there's a lot of other issues that come along with them. So obviously they can cause sedation, respiratory depression, nausea, vomiting, ileus, urinary retention. You can have allergic responses and pruritus. So there's a lot of issues that come along with opioid use, just not dependence and addiction. Now, when we look at the recent literature, especially as it relates to total knee replacement, we know that opioid use comes at a significant cost. So this is a recent paper in JBJS where they looked at patients who were opiate naive going into a knee replacement, and they looked at the percentage of patients that were still on opiates 15 months after their knee replacement. And look at what they found. 10% of our total knee replacement patients were still taking opiates 15 months after their knee replacement. And these were patients that were opiate naive going into surgery. This is another recent study looking at the impact of the opioid prescription at discharge after knee replacement and the long-term use of opiates at 5 months. What they found was a direct link and a direct correlation to the size of the opiate prescription at discharge and the risk of the patient still being on opiates 5 months after surgery. So if we look at other research articles on the impact of opiates, we can see one of the #1 killers of women is due to opioid overdose, right? It's not antidepressants, it's not benzos, it's not illicit drugs. It's actually opioid use is leading to a significant amount of mortality. Again, you can see all the research here looking at opioid use and their impact preoperatively, postoperatively, and what is our role as orthopedic surgeons in trying to address this epidemic. So we have a lot of options that many of us have heard about, but the literature and the science around it is not that robust. So we can see some of the alternative medicine treatments that are listed here. You can see a lot of them help with pain, stiffness. The problem is, again, the research in this space is really not that robust and not that strong. So oftentimes for my patients, when they ask me what are some options to manage and treat their knee OA, I tell them that these are all viable options. But again, the science is not that strong. They certainly aren't going to hurt you. And if you have the resources and the means to try it, then feel free to go ahead and try it. We have some emerging and new information around braces. So this is a thigh sleeve, for example, that activates the VMO. And this was a randomized study looking at the impact of this thigh brace on knee OA and pain and function. What they found was a significant improvement in the patients that received the thigh sleeve compared to the control group. A newer treatment option that has come on the scene is neuromuscular electrical stimulation. We know quad atrophy is directly linked with pain and decreased function. So as the arthritic process becomes more and more severe. Patients have pain, which then limits their motion. When they limit their motion, they don't activate their quads become atrophied, and then we start creating more pain because the quads are atrophied, and you start developing subtle instability, and the arthritic process begins to wear because you have less and less stability, and then we end up having this vicious cycle. And so one of the opportunities is to retrain the quadriceps muscle. So can we strengthen the quadriceps muscle in a way that we can improve the patient's pain and function? Now, the problem here is typically we would send our patients for formal physical therapy. And most of my patients, while they may do a little bit of physical therapy, once their physical therapy ends, they stop doing their exercises and the pain recurs. And is it really practical, and does it make sense that we're going to be sending our patients for quad strengthening and physical therapy for the rest of their lives? No. So how do we impact one of the fundamental issues with NeoA, which is quad atrophy or quad weakness, by deploying or using new technologies that help reduce the total cost of care? Because again, it's going to be expensive if we send our patients to physical therapy for the rest of their lives, and it's also impractical. So this was a randomized controlled trial looking at neuromuscular electrical stimulation using one of the new knee braces to figure out if we activate the quads and we passively stimulate the quads with electrical impulses, can we improve the patient's pain and function? This was a multi-center randomized controlled trial where patients were randomly assigned to get full dose of neuromuscular electrical stimulation versus a sham treatment. And what we found is the patients with the full treatment, neuromuscular electrical stimulation, had statistically significant and clinically significant improvement in their pain and function while wearing the neuromuscular electrical stimulation brace. Now, the one caveat to this is patient compliance. Is just like with anything, patients need to wear or utilize the brace in order to achieve its maximal benefit. So if you look at the patients that actually wore the brace as prescribed, which was 20 minutes, you saw a significant reduction in their pain and a significant improvement in their function. So neuromuscular electrical stimulation is a new option that we can use to help support our patients with NeoA. There's a lot of emerging interest in looking at food as medicine. So here are some studies looking at essential amino acids and their reduction in pain and the improvement in inflammation. And so there's a lot of information now, a lot of interest in prescribing or teaching our patients about healthy food choices and potential amino acid supplements to their diet to help reduce their pain, not only for NeoA, but potentially for total knee replacement as well. So there's a number of vitamins and nutritional supplements that are out there. We've got antioxidants, glucosamine, chondroitin is kind of the classic. We've been using that for some time. We've got vitamin A, C, D, and E. Again, there are some positive results with these treatments. I typically tell my patients that if they don't see a benefit within 8 weeks, then chances are it's not likely going to happen. The challenge is most of our patients will actually stop taking it because they don't necessarily feel a benefit. And then they start taking again, because all of a sudden when they stop taking it, they start feeling that pain, inflammation, soreness, stiffness starting to come back. And a lot of these supplements were actually incrementally and slowly improving their symptoms. They just didn't realize it until they actually stopped. And then when they stopped, they realized that it was providing the benefit that they were looking for. Again, my philosophy with this is most of these treatments aren't necessarily going to hurt the patient. They can potentially help. So again, if they've got the resources and the ability to try these, then I have no issue for them to go ahead and try it. Now, most of us are used to some of the stronger prescription-based medications that are out there, aspirin, ibuprofen, naproxen, or naproxen. Again, we all have to pay attention to the systemic effects of these medications that are becoming more and more commonplace. So obviously, if the patient has history of GI bleeding or any ulceration, patients that have cardiac history, and now hypertension. So a lot of the primary care physicians are reluctant or don't want us prescribing NSAIDs, especially with patients that have hypertension. And again, dealing with patients with NeoA who are an older population, I mean, a lot of my patients have hypertension, so it's becoming harder and harder to prescribe some of the more classic treatments that we've been prescribing. again, because of comorbidities, and the science is starting to tell us that those treatments may not necessarily be as safe as we thought they were. So glucosamine chondroitin is one of the classic supplements that has been around for some time. If you talk to your patients about trying this supplement, try to improve their pain and reduce their inflammation, hopefully reduce opioid use, you should ask them to take 1,500 milligrams of glucosamine and 1,200 milligrams of chondroitin. So again, we found that it improves pain, tenderness, mobility. They have a better side effect profile. Occasionally, they may have some GI intolerance to it, but for the most part, most of my patients do well. But again, the science around this is not as robust as we hope and expect this day and age when we talk about different OA treatments. And there may be a significant placebo effect. But again, it's one of those things where if the patient can afford it and there's very little harm and it potentially can help, then why not? The basic science around this, especially with chondroitin sulfate, is pretty strong. And so when we look at in vitro, the exposure of cartilage cells or synovium to chondroitin sulfate, we see its ability to stabilize the collagen or stabilize the cartilage. It has an anti-inflammatory component to it, and chondrocyte viability improves. So there was an entire issue of osteoarthritis in cartilage completely dedicated to chondroitin and glucosamine that showed and demonstrated a lot of basic science or cellular impact of these supplements. The problem is when you take it orally, does that necessarily translate into what we see in the lab? This was a New England Journal of Medicine article looking at glucosamine chondroitin, large randomized trial comparing the efficacy of glucosamine chondroitin. And what they found was that glucosamine chondroitin really did not provide that much relief. The challenge with this study is they used the Kellgren-Lawrence scale to assess severity of disease. And we know that X-ray is taken only one view with the patient standing in the AP plane. And we know that you need the merchant view and the tunnel view to really assess the severity of disease. So they may have enrolled patients with more severe disease, which may have explained why the glucosamine chondroitin group didn't do as well. So again, when you're looking at the research, you have to look at it critically and understand, does the methodology and does the science really fit with the way you know and the way you think your practice should be running. There's a lot of interest in topical versus oral NSAIDs, again, with the hope of reducing opioid use. So this was a study done by AHRQ looking at the impact of topical versus oral. They both were effective. The issue that you've got is you're trading off one side effect for another. So the dermatologic issues that you get with topical NSAIDs versus systemic issues that you get with oral NSAIDs. So what their review found is that both type of NSAIDs actually work well. The difference is you have to kind of pick your poison in terms of the complication of the side effects that you are willing to tolerate. So there's a lot of interest now in emerging data looking at denervation of nerves around the knee. This was most recently included in the AAOS guidelines, which were published very recently. So RF ablation is gaining a lot of popularity and a lot of momentum to target the deep geniculate nerves that innervate the bony sources of pain around the knee, so distal femur and proximal tibia. So you can see on this diagram here from the study where they're typically targeting the deep geniculates, the superior medial and superlateral right at the beginning of the flare along the distal femur, and then the inframedial branch along the flare of the proximal tibia. And then you can see the impatellar branches and the middle branch along the distal femur. And so burning these nerves, we found, has provided a fair amount of pain relief to a number of patients, but actually targeting those nerves and deploying the technology to get reproducible results has still been a challenge. This is very technique dependent. The deep geniculate nerves are an extremely important target for managing knee OA. Now, we know that the pain drivers for knee OA are most likely both soft tissue and bony. And the deep geniculate nerves, remember, are branches off the tibial nerve, and they innervate the distal femur and proximal tibia. When we look at branches of the femoral nerve, we see that they mostly impact surgical pain, not so much knee OA pain necessarily. And so the deep geniculates are responsible for a significant amount of the bony pain, because as that articular cartilage wears, those forces are transferred to the surrounding bone behind that area of arthritic change. And we know that the cartilage is aneural. And so this pain sensation is coming from the underlying subchondral bone. And so what are the nerves that innervate that underlying subchondral bone? Well, it's the deep geniculates that are branches off the tibial nerve. And so that's why targeting the supermedial, superlateral geniculates, as well as the inframedial geniculates, can help denervate the bony pain associated with areas of arthritis. Now, the challenge is when we burn these nerves, is we're causing permanent nerve damage. We're essentially causing a scar ball at that location. And we also know that there's a vascular supply that accompanies those nerves that go up to the patella and create a plexus around the patella. So some of the issues with burning and radiofrequency ablation of these nerves is worrying about aberrant nerve regrowth. So as those nerves regrow and try to reinnervate the areas that were destroyed, they potentially can cause some rebound neuropathic pain. Also, some worry in terms of the vascular supply that accompanies these nerves and potentially knocking out vascular supply to different structures around the knee. The other issue is if the technique is not done well, you can potentially treat or get the radiofrequency probe intra-articularly, and then potentially cause a septic knee, which you have to be careful of. We've published on some new technologies looking at freezing some of the peripheral nerves around the knee. So a technology called cryoneurolysis to target the superficial sensory nerves around the knee, targeting interpatellar saphenous branches along the medial proximal tibia, and the anterior cutaneous branches and the other cutaneous branches along the anterior aspect of the knee. And these are two studies looking at the impact of freezing nerves and reducing pain in the surgical space, reducing narcotic consumption and total knee replacement. And another randomized controlled trial looking at freezing those superficial sensory nerves and reducing knee OA or OA-related pain, which was recently FDA approved based on some of this research. So targeting the femoral nerves are an interesting opportunity to address OA pain of the knee. Now, previously we talked about the tibial nerve driving some of the bony pain around knee OA. The terminal branches of the femoral nerve are also responsible for a significant amount of pain around the knee. Now, the terminal branches of the femoral nerve do not innervate the proximal tibia. So we know that pain that may be tibial based is going to be bony and driven by the tibial nerve. But we know a majority of our patients, when they come in with knee OA pain, generally report anterior knee pain. So if we look at the anterior knee, specifically the patella, and theoretically the trochlea and the synovium and the soft tissues around the anterior knee, those are predominantly driven by the femoral nerve, or the terminal branches of the femoral nerve. And so if we look at those terminal branches, the anterior femoral cutaneous nerve and the infrapatellar branches of the saphenous nerve are innervating that anterior soft tissue sleeve. And so targeting those superficial sensory nerves can eliminate or help a significant amount of knee OA pain that is driven by those anterior soft tissue structures. So on the right is a study, randomized controlled trial, again, where patients were randomized into freezing of the sensory nerves around the knee, superficial femoral sensory nerves, compared to a group that got a sham treatment. And what we found was a statistically and clinically significant improvement in the patient's knee OA pain in those patients that received for the cryoneurolysis of the superficial sensory femoral nerves around the knee. So this is just a diagram showing where we would target the superficial geniculate nerves. So you can see the anterior femoral cutaneous nerve, approximately 7 centimeters proximal to the patella, and the impatellar saphenous nerve medial to the patellar tendon. So when we look at opioid use, what we're trying to understand is not only what the clinical impact is, but at a system level, at a kind of more holistic level, how does using opiates impact adverse events, total cost of care, and the overall health of a patient? And so this was a database study that we performed looking at 3 different treatments for managing NEOA vis-a-vis opioid use. And so we looked at HA use, intra-articular steroid use, and total knee replacements. And we wanted to see how those different treatments impacted opioid use in this huge database from Blue Cross Blue Shield. So we looked at 260,000 members within Blue Cross Blue Shield who had their first diagnosis of knee arthritis in 2013. And then those patients had to be continuously enrolled in that health insurance plan for 4 years. So we could track all the different treatments that they received. They could not have received HA, corticosteroids, or total knee replacement prior to January 1st of 2013. So they were essentially clean, if you will, coming into the study. We also wanted to ensure that they didn't have combination therapy. So we looked at steroids only, HA only, and total knee replacement only. And then we looked at all of these outcomes that you see here. So adverse events, complications, opioid use, and then the costs associated with that. So this is just a breakdown of the size of this database. So you can see fairly large, mostly younger patients. So this was a commercial payer, Blue Cross Blue Shield. So small Medicare population. So the bulk of the patients were commercial. Again, 46 million lives that were covered during that time period. We had a little over 250,000 patients who qualified to be in this study. And 126,000 were taking monotherapy, so only HAs, only steroids, or only knee replacement. And what did we find? So as expected, because this is a commercial database, not a Medicare database, you can see the bulk of the patients which between 40 and 64 years old. You can see the gender difference here on the right. So pretty consistent in terms of gender, about 50-50 for the most part, except you can see here there were a higher number of females receiving steroids compared to males. And what we found was, interestingly enough, that the percentage of adverse events was actually lowest in the HA group. And steroids actually had a fairly high incidence of adverse events compared to HAs. You can see total knee replacement in blue had the highest number of adverse events, as you would expect after knee replacement. But steroids actually had significant number of issues when we looked at the total number of adverse events and we start controlling for all the medical comorbidities of our patients. If we look at opioid use, looking at total knee replacement versus steroids versus HAs, this is really interesting. You can see the first year after knee replacement, we would expect the total knee replacement patients to have much higher opioid use, but that drops off considerably in year 2. As you would expect, patients have healed from their knee replacement, and so they're not taking pain medicine nearly like they were in the beginning. But if we look at the steroid group, look at this. They are consistently fairly high compared to the HA groups over that 4-year time period. And then look at this. The HA group actually is equivalent after 2 years to the total knee replacement group. So patients get their total knee replacement. They have high opioid use. After 2 years, their opioid use dramatically decreases to the point where it's equivalent to the HA group. So HA and total knee replacement performed better than steroids when we look holistically at opioid use over those 4 years. Now, if we look at this from a health economics perspective and from a cost perspective, we can see that the total cost related to a knee replacement is fairly expensive, as you'd expect, the cost per member per month. But steroids had a much higher cost, overall cost, in this group over the 4 years compared to hyaluronic acid group. So again, when we control for all these different variables out there, right, comorbidities, age, gender, and all of those demographic variables, you can see that HA injections had a total lower cost of care compared to steroids and lower than total knee replacement. So when we look at the cost by adverse event, you can see when we look at the cost of each one of these adverse events and then we look at what that cost averages per member per month, again, you can see in the HA group a significantly lower total cost of care as it relates to the adverse events compared to the corticosteroid group and the total knee replacement group. And interestingly, look at this, the steroid group actually had higher costs as it relates to adverse events compared to a total knee replacement. So when we start looking at these parameters at a macro level and we start aggregating this level of data, millions and millions of data points or hundreds of thousands of data points, you start to see signals that we couldn't necessarily appreciate at our individual practice level. When we look at the cost of opiates as it relates to the three main treatments for knee arthritis, what do you see? You see a significantly lower cost associated with HA injections compared to steroid injections and then total knee replacement. So look at how consistent the cost related to opioid use and steroids are compared to total knee replacement and HA injections. And look at 3 to 4 years. HA injections and total knee replacements have the same cost of opioid use compared to much higher costs related to steroids. So in this large Blue Cross claims database review, members who used HA injections had fewer adverse outcomes and used less opiates compared to corticosteroid or total knee replacement only patients. Costs associated with these adverse events were much higher in the steroid and total knee replacement group. And after we adjusted for everything, all the patient comorbidities, overall healthcare costs were lower in the HA group compared to the steroid or total knee replacement group. So in summary, we've got a growing number of non-pharmaceutical treatments. We've got a lot of new innovations and a lot of new opportunities to manage our patients with knee OA. We can target regional nerves. This is becoming an area of growing interest where we're starting to realize where the pain generators are in the knee, and we're starting to treat knee OA kind of further upstream in the pathology than the final end result, which typically in the past was treated using opiates. We're starting to identify that quad strength and muscle dynamics are important in terms of managing knee OA pain and function. And I think it's fairly obvious to all of us now that opioid use is linked with significant costs and adverse events. So I get asked a lot of questions in terms of the different ways that we can manage knee OA. You know, one of the questions I get asked is, what do we do with patients who are bone on bone, who are younger versus older? What treatments do I use based in which patients? And so my typical algorithm is I split patients up kind of into 4 categories. So I've got my younger patients with mild to moderate OA. I've got my younger patients with bone on bone arthritis. I've got my older patients with mild to moderate knee OA. I've got my older patients with bone on bone arthritis. And so in those groups, you know, what do I use and when do I use them? And so if we look at patients with mild to moderate knee OA, typically based on their age, I'm going to deploy a pretty similar algorithm. So typically, you know, again, it'll be exercise and NSAIDs and all those typical things. And then I use HA injections as my first line treatment because they're chondroprotective and they've been shown to help. And then we'll move on to more interventional treatments, if you will, like cryoneurolysis or NMES or other treatment options that are out there. But where things get tricky is with our bone on bone patients. And what do we use and when do we use them? So let's say I've got a 55-year-old patient with bone on bone knee arthritis. You know, what do I do for that patient? So my general philosophy with them is I'm going to throw the kitchen sink at them. I'm going to try everything possible in the toolbox to try to delay or avoid a knee replacement as long as possible. So with them, even though some of the data around HAs in severe OA aren't necessarily that great, again, my overall goal is to avoid knee replacement if I can, and most certainly try to avoid opioid use, especially in younger patients. And in that group, I will basically go through the entire treatment options with them. Again, starting with weight loss and NSAIDs, you know, we will try HA injections, even if it's bone on bone. We'll try toradol injections. We'll try steroid injections. We'll try cryoneurolysis, NMES. We'll try radiofrequency ablation of the deep geniculates, long-acting steroids if we have to, all in the hope of trying to avoid opiates and total knee replacement. Now, let's say I've got a bone-on-bone patient and they're 70 or 75 years old. Am I really going to go through all of that to try to avoid knee replacement? In that situation, I actually think that delaying knee replacement is actually causing more harm and the patient's actually digging a hole because the older you get, the harder it is for us and the higher risk it becomes to consider a knee replacement. So in that group, I will try 1 or 2 things. demonstrate that whatever injection or whatever treatment isn't working, and then we'll go ahead and move on to a knee replacement. Because let's say I try to buy 5 years and you're 75 years old, and now whatever I'm using isn't working. Now you're 80 years old going into a knee replacement, whereas we could have done it when you're 75. And most of my patients over the age of 70, all kinds of things start to pop up in their lives. Maybe their spouse gets sick, they start having health issues. All of these things start cropping up as you get older. And then all of a sudden, doing a knee replacement is not practical, or it becomes unsafe, or unnecessarily high risk. And so again, the context in which the patient is will influence what treatment option I use. Again, let's say I've got a patient who's young and working and can't take time off of work, right? So there's so many different parameters, or the type of insurance they've got. Maybe they've got a high deductible or they've got Medicare. So many different factors come into play in terms of how I choose my algorithm to treat the patient's knee OA. Again, ultimately, all in the hope of trying to avoid opioid use pretty much at all costs. Another question I frequently get asked is, when we use HA injections, how do we use that in the context of other treatments that are out there? So, for example, can I mix it with steroids, or can I use it with PRP or other biologics that are coming down the pike? And so typically what I tell folks when asking, can I mix and match HA injections or other injections, is really there's no science there to support it. I've seen a lot of folks use steroid injections either just before an HA injection. Occasionally, they'll actually mix it together, or they'll bring the patient back after the HA injection because they're worried about an inflammatory reaction. Now, we see that inflammatory reaction specifically with certain types of cross-linking and certain HA injections. We don't necessarily see that routinely. And so for the majority of HA injections that are out there, you shouldn't necessarily have to use steroids either before, during, or after. There's really no data or science to support mixing them together. And so you have to use your clinical judgment if you think there's some type of inflammatory reaction or something linked to your HA injections that you feel steroid injections would be helpful. Now, I've got some people that have asked, and actually they've got kind of a red, angry, swollen knee, that they'll actually try to quiet it down with the steroid injection ahead of time, then bring the patient back the following week, and then give them the HA injection to get that more long-lasting relief. And so I think there's a number of different ways that you can slice it and dice it. The challenge with biologics such as PRP, placental tissue, and things like that is, for the majority of patients, it's a cash-only treatment option, not really covered by many insurance plans. And so for my patients that talk to me about using biologics, what I tell them is really the science and the evidence doesn't support their use as strongly as we hope. We're still waiting on more robust science to show the efficacy of PRP and amniotic or placental tissues, but the early science looks promising. And so if you think that it's helpful and you've got the resources that you can afford to pay for it, and if it doesn't work, it's really not an economic challenge for you, then I will offer those kind of newer orthobiologic interventions if the patient asks for them. So again, in this kind of new injection space, the data and the science is evolving, but we have to really try to ground our patients in the science and try to help them make the best decisions based on the context of their situation. So whether they're fixed income, what type of insurance they have, how often they can come, the severity of disease, all these different variables we have to bring in to try to deliver the most optimal treatment for our patients. So let's review a couple case examples and look at potential options for some of our patients. We all have challenging patients that come to our office where we don't necessarily know what the best treatment options are for that patient. And I think the areas that most of us struggle with are the younger patients with moderate to severe disease, where we're not sure exactly what the best treatment option could be. So let's look at a couple case examples and see what the different options can be for some of these patients. So this is an example of a 49-year-old woman who's active duty military. She's complaining of anterior knee pain, has occasional swelling, worse with high impact activities. Over-the-counter medications aren't working. They don't have time for repeat office visits. If we look at the x-rays here, we can see a mild amount of knee OA. So I want to kind of point out the different x-ray views here that I think are really important in trying to categorize and assess the severity of disease of knee OA for our patients. So this is a sunrise or merchant view. You can see the patella sitting nicely within the trochlear groove. And here, what we're looking for is either subluxation or tilt of the patella. And then we're looking at the joint space to see if there's a significant amount of narrowing. So again, when we look at the KL score, which is how a lot of insurance companies want you to dictate to see if the patient's a candidate for different treatments, that KL score doesn't account for the patellofemoral joint. And we know the patellofemoral joint is actually the number one place where most of our patients actually complain of pain. Most of our patients actually point to the front of their knee when they come in to see you complaining of knee pain, but yet that's the one area we don't necessarily image with an AP and lateral knee x-ray. So you really have to get a sunrise or merchant view to really assess the patellofemoral articulation, because that's going to be the first place where we're going to see degenerative changes in symptomatology with our patients. This is on the right here, a standing AP knee x-ray. You can see well-maintained joint spaces. I don't see any osteophytes here. But the problem with this x-ray is we are only profiling the distal femur. We're not looking at the posterior condyles of the femur. And where do we expect most of the arthritic process to be? We expect it to be along the posterior condyles of the lateral femoral condyle and the medial femoral condyle, because we spend most of our lives in flexion. We don't walk around peg-legged in straight extension. So if we look at the notch view or the tunnel view, now we bring into profile the posterior aspect of the femur where we would expect the articular cartilage where to be. And all of a sudden here, you can see you got a little more narrowing medially compared to laterally. So we're starting to see early arthritic changes here. Again, no osteophytes. So I think the tunnel view and the sunrise or the merchant view are actually the two most important views, in my opinion, to assess OA severity and to assess how bad their arthritis is. The lateral view is helpful, but again, not as helpful as some of these other views when trying to assess OA severity. Here, you can look at and look for osteophytes along superior polypatella, inferior polypatella, some other subtle things that you can look at. And so this patient here in this example has, I'd say mild to moderate knee OA, active, relatively young, and our normal treatment options aren't necessarily working. So anti-inflammatories, I'm not going to be telling this patient to lose weight and exercise. They're already very active. And so what are our options here? We could potentially give steroid injections. So again, there's a practical component to this where steroid injections don't require insurance authorization. They're readily available in all our offices. But in a patient like this, I don't necessarily want to inject something that's chondrotoxic. We know that steroids plus the analgesics that we give can harm the cartilage cells and cause biologic issues within the knee. So I like to withhold typically those more toxic treatments for later in the disease process or later in the algorithm where I'm running out of options. So this is someone that needs kind of reliable pain relief. They've got mild to moderate knee OA. They don't want to come back for repeat visits. So multi-injections, such as the older HA injections, may not necessarily be the fit for this patient. So this may be one, again, based on the data, that total cost of care, adverse events. If we look at the basic science of HA injections, that they're chondroprotective. We look at the clinical evidence that they help reduce pain and inflammation. This may be someone where a single injection HA is helpful, and this may be someone where you would consider using that type of injection. Here's another example of an older patient, so 69 years old. They've got a lot of medical issues here. You can see diabetes, peripheral vascular disease, hypertension. They've had recent bypass surgery, pain and difficulty going up and down stairs. So again, as your OA progresses, the two most common things that I find is related to the patellofemoral joint. So they have trouble getting up from a sofa or a couch or a chair, especially a low chair or the toilet, and they have trouble going up and down stairs. And so that is the hallmark that they're starting to develop a fair amount of specifically patellofemoral OA, not just necessarily tibiofemoral OA. You've got limited over-the-counter options, right? Because of their medical comorbidities, NSAIDs and all those other options aren't necessarily safe for this patient. This is an older patient. Again, a lot of my patients may have family help, may not have social support. So a lot of these factors start coming into play as we try to figure out what the best treatment options are for these patients. I've got patients that have to take the insurance-based transportation to get to all of their appointments. And so if you've got patients that are poorly resourced, can we bring them to the office multiple times for all these different treatments, or do you try to find things that last as long as possible? So on these x-rays, again, you can see the merchant view here. Tough to tell if there's joint space narrowing. You can see here on the notch view, you see narrowing. On the AP view, I can see narrowing. You can see the atherosclerosis of the popliteal vessels in the back here, some early osteophytes along the superior inferior polar patella. So this is a patient that has moderate knee OA, older, with a fair amount of medical comorbidities. So again, this may be someone where a single injection HA may be most appropriate because they're struggling with social constraints and social determinants of health, their medical comorbidities. And so we need to get them an option that may potentially last as long as possible. So with that, we will pause and turn it over for Q&A. Thank you. Thanks, everyone. So we now have some Q&A time. So we'll go into some of the questions and discuss some of the answers that our audience has given. Please enter your questions in the chat and comment section, and then we'll go ahead and answer them as they come in. So the first question that came across the chat room is around insurance plans. So the question is, I work in rural Arkansas, and the BCBS plans I deal with typically do not cover HAs. How are you getting BCBS to cover these? Honestly, I'm in Louisiana, and we have no issues with coverage from BCBS. So for us, it's really not a challenge. I think, one of the subtleties to think about as you use HAs, and it's just understanding how the system works. And so one of my recommendations is if an insurance company does, and an insurance company, particularly let's say BCBS, doesn't cover HAs, don't stop ordering them. Continue to order them knowing that you're going to get the denial, because what the insurance companies do is they run analytics, and one of the measurements that they use is the number of denials for a given treatment, whether it's surgery or injections or what have you. So if you got a particular payer, actually keep ordering it, get the denial. So that way it gets logged into their database. And so when they run the analytics, they can see, wow, this thing continuously keeps getting requested. And then they extrapolate member satisfaction, provider satisfaction, and that triggers them to go back and look at that treatment or that procedure that you're trying to get done. So I would encourage you to keep ordering it. With whatever payer you want to do, keep ordering the specific injection that you want because it helps build the narrative and helps generate momentum for the future. So don't discount that. So you're going to have to do some work if you think that these treatments are appropriate for your patients. We've got to kind of still band together and do that work to try to get the different payers to cover this. So that's my recommendation there. And if they don't cover it, you're kind of stuck. You can do the appeal and go through that whole process. But a number of BCBS plans cover it all across the U.S. So when you do that appeal or that peer-to-peer, you can probably point to all the other Blue Cross plans in neighboring states probably that do cover it. You can tell them, look at Louisiana if you want, and hopefully they'll change their mind. Next question coming down the pike is, when considering a total knee replacement, do you have any restrictions on BMI, and do you prescribe any prehab to assist with quad strengthening prior to surgery? If so, what are the outcomes for those patients? So my BMI cutoff is a little different than others. Mine is a hard cutoff at 45, and then a soft cutoff at 40. So in other words, 40 and below, I'll definitely offer surgery. 45 and above, I definitely will not offer surgery. Ask them to meet me halfway there and help optimize and reduce their risk if their BMI of over 45. And between 40 and 45 for me is a gray zone. I think it depends on kind of who the patient is, their body habitus, have they been trying to lose weight, and those kinds of things. So I give myself a gray zone there to use my clinical judgment in terms of whether or not, total knee is the appropriate option for that patient and kind of where they are in their journey and all that kind of stuff. So I think it gives me a little leeway. It gives me the ability to work with patients and not have a hard and fast cutoff where I feel like I can work with the patient. So for example, let's say someone had a BMI of 50 and they're losing the weight. If I had a BMI cutoff of 40, I wouldn't do surgery. But let's say that they're at 50 and they're down to now 44. They've been doing the work. They've been trying to, and they understand the risk of infection and complications. We have a shared decision-making process. They've got a BMI 44. They've dropped. They're miserable. Injections, nothing's working. But they're doing the work to get there. That's someone I don't necessarily want to deny a total knee replacement for. So again, it just gives me the ability to maneuver and meet my patients where they are and help them the best I can. So, it's a hard, definite yes, below 40, definite no, above 45. And then between 40, 45, it's kind of my discretion. So that's kind of how I built my criteria, if you will. The second half of that question is around prehab. Do I typically send my patients for prehab? It's rare that I'll send them for preoperative physical therapy for quad strengthening. Now, there is data and research to support that. I think the gains from that are fairly nominal and fairly minimal. So I think the juice isn't worth the squeeze, if you will. So there is some improvement. There's also a word of caution because I've had patients where they burn through a lot of their physical therapy unnecessarily. There are insurance plans where you only get a certain allotment of physical therapy a year. And so if you burn through that physical therapy, let's say early in the year, I've had instances where, I do a total knee replacement in, let's say, mid-November, and they run out of physical therapy visits for that year. And all of a sudden they're on hold for 3 weeks, right in the middle of their physical therapy after their total knee replacement until January 1st, when the number of visits resets. And so that's a subtlety and detail that a lot of people don't necessarily pay attention to. It doesn't happen often, but I've had a couple instances where, the patient has been struggling because we burnt through all their therapy. Not me, but, they had other issues going on. And so I'm a little leery about prescribing prehab, formal prehab. Maybe it's 1 or 2 visits to learn those exercises so they can do the quad strengthening preoperatively. There are new technologies, like you saw, around neuromuscular electrical stimulation, where, could we passively build up quad strength with new innovations and technologies so they have stronger quads going in, so then they can have improved outcomes coming out of surgery. So that's why I think, innovating and doing and deploying new technologies to deliver that outcome may be a more efficient utilization of resources, time, and energy. So I do think building preoperative quad strength is a good idea, but the mechanism to do that traditionally with all this physical therapy, I think we've got to find better ways of doing it. So yeah, I do believe in it, but I'm going to start using kind of these newer technologies to see if we can get there without necessarily using traditional physical therapy to the extent that traditional prehab has kind of prescribed. So can we kind of relook at that in a different way? Next question is, what opinion do you have regarding per visit cost of corticosteroids versus HA injections? We have a lot of immigrants or folks with terrible insurance or no insurance that choose steroid shot out of opportunity cost over HAs. The out-of-pocket expense is immense for HAs compared to corticosteroids. And so I agree with you. That is something to consider. The total cost of steroids obviously is a lot cheaper. And so you've got to kind of meet the patient where they are. There's no silver bullet. There's no right answer for each patient. And so if you're a cash pay patient and you need immediate pain relief because you got to get back to work because you got to pay rent, ultimately, having a roof over your head and food to eat probably trumps some of the deleterious effects of short-acting corticosteroids. Right. So, we've got to treat our patients based on their situation. In an ideal world, yes, especially for mild to moderate OA, I'd like to give HA injections and then steroids later on as disease severity progresses, and all that kind of stuff. But not all our patients live in an ideal world, and we don't all live at Disney World. And so we've got to kind of practice based on the circumstances. And so, yeah, I do have patients in that same scenario where, they need something, and they got to leave that day with some relief. And so I'll give steroid injections, and again, it's an educational process. I teach the patient to the best I can, and we all come up with the best option or best decision for that patient, and then we execute on it. And so, like I said, in some instances that is the right option for that patient, given everything. So biology doesn't necessarily trump, their social circumstances and all the other issues that make life complicated.